Hi, good evening, good morning, good night, depending on where you are. Welcome to our third cochlear implant webinar in the platform of OTOALEX and Egyptian CI. I welcome all of you in this webinar. We had two previous webinars. One was on CI for meningitis from A to Z. It was by a distinguished panelist. And the second one on subtotal petrosectomy was done by Professor Lubna Pei. And you can watch both of them on youtube.com/c/OTOALEX. Tonight we are going to have the third webinar. It will be on CI surgery and basic concepts. And we are lucky tonight that we have a very distinguished panelist. The first of them, Professor Aziz Belal. Professor Aziz Belal, on a professional level, he is a pioneer of cochlear implant, not only in Egypt, but in Middle East. He started the cochlear implant since last century, at the end of the last century, I think more than 35 to 40 years doing cochlear implant. He came from the US and he started his program of cochlear implant in Egypt and then in all Arab, most of Arab world. And Professor Belal we consider him as the godfather of cochlear implant in Egypt. On a personal level, Professor Belal is my teacher. He is my friend. He's that kind of man that when you need him, you find him. So I would like here to take this occasion and thank him for what he taught me. And we hope that you are going to enjoy all his expertise. He has one of the biggest series, if not the biggest. He had one of the big series in cochlear implant in Egypt. And he is, beside that, is a very good teacher. Professor Mohammed Shazli. Professor Mohammed Shazli, he is actually one of a talented surgeon. He has a very, very big series of cochlear implant. Very well experienced in difficult situation. Professor Shazli also is a brother and his friend, and he is a very kind person. Really, I usually enjoy talking to Shazli. Lastly, not leastly, Professor Ali Mahrous. Professor Ali Mahrous, I can consider him as one of the stars of cochlear implant. He was always in UK and then he joined us last year, a few years ago. And he is one of the rising stars in cochlear implant in Egypt, besides being a famous otologist. So I hope that you are going to enjoy this webinar, and I will give them the whole opportunity to give all their expertise in this field of cochlear implant. Disclosure, I have nothing to disclose. This is a purely scientific meeting. You don't have any company joint meeting. Some of the pictures, some of the figures are taken from references and they are referenced. You can find the reference below. So I don't have anything to disclose more than that. I'm going to skip the audiology, most part of the audiology, because there will be a panel or a talk on audiology in CI. But here I'm going to concentrate on surgery. So to start with, we are speaking about a child, mostly below 5 years, who had profound hearing loss and had a powerful hearing aid. And despite the powerful hearing aid, he didn't benefit from hearing aid. He didn't progress in language, and the family and the speech therapists are not happy with the response. And when he did an aided pure tone, you can find that the aided pure tone is worse than 50 decibel. In that case, the benefit of the hearing aid is not that good, and he's going to shift to a cochlear implant. So now we are going to talk for the surgeons what to do in these conditions. My first question to the panelists, all of the panelists, when do you consider, all of them have busy clinic, have a lot of cases, have a waiting list. So my question is, when you bypass this waiting list and you recommend an urgent cochlear implant and a fast track for the cochlear implant, what are the conditions? Professor Bilal? Can you unmute Wael for Bilal? Dr. Aziz?
Yes. Can you hear me now?
Yes, please.
Okay. So I think the fast track for these kids, at least if they have a case of meningitis, of course, then you'll have to do a fast track cochlear implants before the ossification sets in the cochlea. One thing that if the child is a little bit older than 2 years, I think if he approaches the time of 5 years or 4 years, then you'll have to be fast with him, because those kids are scheduled to go into school at 6, and they need to be hearing, and they need to have at least a little bit of speech so that they can be enrolled in a normal school. So those are the fast track children that I would think of.
Professor Shazli or Ali, you want to add anything? Professor Shazli?
I totally agree. Do you hear me now?
Yes.
I totally agree with Professor Bilal. In addition, I may add something as Usher syndrome if the patient has multiple healthy gaps. So I prefer to help the child with the CI.
So you mean because rehabilitation with vision is better than rehabilitation
without
blindness, so you want to add it in such a list. So we have 2 or 3 conditions now which should go for fast track. Don't let them in the normal track. Professor Ali?
Yes, I think I totally agree with has been suggested by both panelists. Fast tracking is really meant for post-meningitic children, but also there is a situation which is fairly uncommon in patients with head trauma, severe head trauma, leading to a skull-base fracture. And these patients, once we confirm that the cochlear nerve is not severed and is intact, probably I would suggest...
I think, Ali, when we mean meningitis, we mean any kind of ossification, labyrinthitis ossificans. So whether it is a meningitis, it's trauma, feeling of ossification.
Yeah, but the trauma...
Ali, what imaging do you request usually in such condition?
Which condition you're talking about? The meningitis?
For cochlear implant. No. For a basic cochlear implant.
What happened, Professor Fathi, is that when we started the career of cochlear implantation, the primary modality of imaging was the CT scan. But as the time passes by and the scientific body of opinion has actually shifted now to MRI scan. Now, I would like to elaborate a little bit more on that. So if we're talking about the postlingual deafened candidates, then probably CT scan would be sufficient. But if we're talking about the prelingually deafened ones, the primary modality now is MRI scan. But that is the mainstream candidates. However, there are situations where I would actually require both modalities, CT scan and MRI scan. For example, in post-meningitic children, for example, then I would actually require both modalities. In children with cochleovestibular anomalies, I would again request both modalities. Now, I am fully aware that there is a cone beam CT scan now, but where I practice, it does not actually exist, so I wouldn't use it. But I am aware through the literature that cone beam CT scan is on the rise. Particularly, it gives even the same information as CT scan with much less ionizing radiation.
So to summarize, we have to ask for an MRI mainly, And in some cases, like malformations, like ossifications, we go for CT scan. This is to reduce the irradiation dose for the children. And the convincing CT, I want to warn against the dental setting. If you are going to use it, don't use the dental setting. You have to use the Petra setting because it gives a very good view. Professor Bilal, what do you look especially in MRI? What is the most important thing you want to know from your MRI? Professor Bilal?
MRI, I don't agree with you that you skip the CT. I think the CT is the gold standard for doing a cochlear implant to see all the anatomical variations of the mastoid and of the round window and everything. So you cannot do a cochlear implant without the CT. But going back to your question, MRI is very essential in children because they show the soft membranous labyrinth and the soft tissues, especially the 8th cranial nerve. You have to be absolutely sure that the 8th nerve is there. And then there are some of those cases where there is a CNS anomalies in the brain stem and in the brain. So you have to be absolutely sure in children that you do not have syndromes associated with CNS anomalies.
So Dr. Bilal now tackled a very important point that you don't look only for the MRI of the inner ear and the cochlear nerve, but you have to look also for the brain because you can find the CMV or whatever, which can hinder the cochlear implant. Dr. Shazli, what you look in your CT mainly? Shazli?
Looking at, do you hear me?
Yes.
We have a checklist. As overall, I would like to look for the Mastoid pneumatization, the position of the sigmoid and jugular bulb, and I would go for next. I go for the basal turn of the cochlea, its relation to the facial nerve, the round window orientation. I would like to go for and see what's happening for the internal auditory canal. Does it optimum size or small size? I would go for to see, of course, see the shape of the cochlea if there is any anomalies. I mean gross anomalies, and sometimes with ossification, although it appears much more in MRI than a normal CT, I may look as ossification in post-meningitic cases, or sometimes if there is any abnormalities considering the otosclerosis. So the CT, as Dr. Aziz has said, carries a lot of information that I cannot get it from MRI. Although the MRI is very essential for some cases, especially for the unilateral hearing loss, for congenital absence of the cochlear nerve, which cannot be detected in a routine CT scan.
So we can consider the CT as the roadmap for your surgery, besides
course, yes.
some conditions like ossifications or fractures. Professor Ali, what medication you would like to give before the operation?
What I actually do, Professor Fathi, is that the morning of surgery, I would, whilst the patient, before transferring the patient to the OR, I would actually advise to give antibiotics, intravenous antibiotics, and the usual one I prescribe the ceftriaxone, basically, and I would give them 1 dose of dexamethasone as well the morning of surgery. Given in a dose of 0.3 milligram per kg. In terms of what you are actually displaying on the screen here is the vaccine. The vaccine, I would recommend giving the vaccine at least 2 weeks prior to surgery. And the type of vaccine that I would recommend, depending actually on the age of the patient or the candidate. As you know, the CDC recommendation is to actually, below the age of 2, is to offer the candidates the Prevnar 13 And after the age of 2, the recommendation is actually Pneumovax 23. That is besides, I would actually give them a booster dose of Haemophilus influenza as well, in addition to the compulsory vaccination which exists in Egypt here.
Thank you, Ali. What we want to stress that the vaccine should be given at least 2 weeks before the surgery, and you should know the CDC recommendations, or you should send it to somebody who knows it, and they write the proper doses. But the most important to give it 2 weeks before the operation. And as Ali said, the antibiotic should be given at least 1 hour, and the most with the steroids. Dr. Aziz, the child is in the operating room, and the anesthetist start putting him to sleep, and you notice that the anesthetist is not very comfortable, and on the screen there was some arrhythmias. How can you prevent that conditions? What do you expect? What is the problem, and how do you prevent it?
Can I get first to can you hear my voice? Can you hear me?
Dr. Aziz?
Can you hear me? Or
can you unmute
no?
The microphone, Dr. Aziz, please?
Hear you, Dr. Aziz.
Can you hear me? Hello? Fathi.
I hear you, Dr. Aziz.
Hello? You
Hello?
hear me? Okay. I want to make 2 remarks, Fathi, on what has been said. The first, I'm again contradicting Dr. Ali in the vaccination. I agree on what he said on the pneumococcal vaccine, but I think the Haemophilus influenza, I don't think that it has a place now for those patients. The second important remark is the value of CT and MRI. I think I'd like to add that the MRI shows the membranous labyrinth in only 20%. So the anomalies that you see in the membranous labyrinth using the MRI are only 20% of the cases. I think if you're doing surgery on children, you have in every case to get into the temporal bone registry. Look into the histology of the temporal bones of the diagnosis you've got, especially in those congenital anomalies and congenital problems, because it will give you an excellent idea about the prognosis of the case, whether you'll meet problems of CSF, otorrhea, and so forth. So this is a must if you're operating on children with auditory neuropathy and so forth. There are so many things that you can learn if you study the temporal bone pathology in a case like this. Getting back to the question of Fathi, I think the arrhythmias are a sign of that you have to examine really the heart of the children to exclude any congenital problems as a part of the congenital syndromes that you're dealing with. So it's a very important point that Fathi has pointed, that we have to send him to a pediatrician, a heart doctor, to examine his heart and exclude any congenital problems as a part of the congenital syndrome.
Dr. Aziz, do you do it? Hello? Hello? Hearing me?
Yeah.
Yes.
Hello? Dr. Aziz, do you think that we should go as a routine in every case with a pre-operative ECG for all children who are going to implant? Is it your routine?
No, if you expect congenital, multiple congenital anomalies in a case as a part of congenital syndrome, then you'll have to send them to a pediatrician. But if you have a case which is straightforward with no signs of congenital anomalies and multiple congenital anomalies or syndrome, then you do the routine examination of the case.
May I have another comment for both you, and for Dr. Ali concerning vaccination? I mean, in my series, it's a large, more or less series. I don't give a pre-operative vaccination. I am giving it in the first week post-operative, and I didn't find any problems with post-operative meningitis that happened to my series. But what's your opinion?
Ali, and I give it like Ali 2 weeks before the cochlear implant because this is the guideline for cochlear implantation. But I cannot answer the question whether you give it after there is a difference or not. Ali, do you have any comment?
Hello, can you hear me now?
Yes.
Yes, can you hear me now? Well, actually, I have worked in different places where they would actually vaccinate the children after surgery. And to be perfectly honest with you, Professor Shazli, probably I share your experience. I found no one child that I implanted had meningitis post surgery. So to be honest with you, I think it's a relative recommendation. I wouldn't say it's a strong recommendation to vaccinate these children before surgery.
Dr. Fathi is there.
Can I go back to the question by Prof. Fathi? When he actually mentioned about the dysrhythmias at the time of surgery and the importance of ECG, I actually routinely recommend ECG well before surgery, because I think the condition that we all dread is the Jarville-Nelson syndrome or Jarville-Lange-Nelson syndrome, where there would be a prolonged QT interval for these children. And these children may have actually sudden death on table. I think it's very important that we actually diagnose them beforehand and be ready to deal with them at the time of surgery. I remember before the Corona time, we had a child that was coming from Sohag, and this child was known to have a Jarville-Nelson syndrome. And we decided to operate on this child when the DC defibrillator ready, external DC fibrillator ready, and we had to get the cardiologist involved. And we have to prepare for an ICU bed after surgery as well. Luckily, we didn't have any problem, but I think we need to do an ECG on every single child who is to undergo cochlear implantation well before the surgery.
ECG before operation. Is the slide already presented? Or,
yes.
Can you see the slide?
Yes,
okay.
Yes.
So we have to do an ECG before the operation to prevent happening of these mishaps. And now we are going to pass through the different steps, and I want to know your tips and tricks in every step, if possible. Shazli, the incision, would you like to comment on your incision, what you do, what you...
Usually I am making the minimal invasive technique. I am using an incision of about 3 centimeters, which is positioned not like this, a little bit superior and posterior. This is the skin incision. Putting in mind that if you go for the incision 3 centimeter and you can make some of subcutaneous dissection, it allows you to go for the periosteum wherever you want to go. So the first, after making an incision of skin, we'll go a little bit anterior, about 1.5 centimeter, and we make a typical periosteal incision with equal distance from the external auditory canal. In such a condition, on such way, you are sure that your skin is away, skin incision is away from the periosteal incision.
What is the advantage of dual incision, Chaz?
Huh?
What is the advantage of this small incision?
Small incision, I mean, I think this is a less incidence of extrusion. And we are sure that the less you are doing for skin injury or the skin the tissue damage, there's incidence of post-operative infection. So I think keeping the vascularity okay, and you are keeping, you are getting better healing with straight small incision.
Any other opinion, Professor Bilal Mahrouz?
I think.
Go ahead, Ya Ali.
Well, actually, the primary advantage of having a small incision is actually you create like a tight closure of the skin, and that is important to help prevent any migration.
Okay.
And I don't think I think you're making your life more difficult by doing minimal incisions. I like to have an L-shaped and do a subcutaneous two flaps which are against each other, a skin flap and a musculoperiosteal flap, so that I'll be sure that my implant is well protected. The blood supply is coming from below, so I don't see any interference with the blood supply if my incision is a little bit larger. We're talking, of course, of post-auricular incision. Some people are still doing end-oral incisions, and maybe you can comment on this, Fathi. I've never done an end-oral, but I know some people are still doing.
This webinar, Professor Lobna presented her end-oral incision, and she's satisfied with it. And I think whoever satisfied by technique and is giving good results, he can keep on. But I think the majority are with the post-auricular incision. Professor Ali, the mastoid, what you want to say about your cortical mastoid?
For the cortical mastoidectomy, I think there are some tricks. The first is that when I expose the mastoid, I make sure that actually I'm exposing very well the root of zygoma, as you are referring to now. And also, when I start drilling, particularly in very young children, I start anterosuperior as much as possible. I am fully aware that I would study the CT scan or MRI scan beforehand, and I know where the anatomy is. But I always teach the residents to actually start as anterosuperior as possible, because that is the safest area. Now, on doing cortical mastoidectomy, I would go parallel to the posterior meatal wall, but it's very important in otology is that the color code is very important. Whenever we drill in the mastoid, once, particularly in the context of cochlear implantation, once you see the color change when you drill a little bit posteriorly, be minded of the lateral sinus or the sigmoid sinus. And superiorly, one has to be careful with the dura, because sometimes the dura is low-sighted as well. So on doing cortical mastoidectomy, I am aware that many would advocate doing cortical mastoidectomy in a way that you would leave the or the posterior border of the mastoid without saucerizing it. I sometimes, particularly when you have a narrow axis, if the lateral sinus is anteriorly situated or the dura is low-sighted, I would actually saucerize the mastoid, because that would allow the light to go into the field and would make things much easier for me when I actually go deep towards the cochlea after performing posterior tympanotomy. So I would drill the root of zygoma, because it would allow more light into the field, and I would saucerize if the axis is narrow, particularly if the sinus is anteriorly situated. And I would drill towards the digastric ridge inferiorly. And what I would do is to leave like a ledge of bone inferiorly that would actually support my electrode arrays inferiorly as well. And obviously, the landmarks for me is the short process of incus and the lateral semicircular canals. And that would be my signpost towards posterior tympanotomy.
But if you socialize superiorly, it will make the electrode can extrude a little bit. I think beveling is very important to keep the electrode in.
Actually,
the posterior tympanotomy, what are your tricks? How do you do it? It's a large posterior tympanotomy, small?
Doctor, can I have a comment, Dr. Fathi?
Please, please.
Yeah. What Dr. Ali have said is marvelous. But what happens when I extrude several facial trauma during cortical mastoidectomy? By some of our colleagues, the main cause that the surgeon goes a little bit down. So I think the most important point to be away of the facial nerve at the second genu is to get the superior part of the cortical of the mastoid. So exposure of the dural plate is crucial in cortical mastoidectomy, which is very nice. You go as Dr. Ali, although I'm not very much with anterior-superior, because if you go down, you may hurt the incus. So I think going or exposing the dural plate of the mastoid is very important. Exposing the sinus plate is very important before getting too far anterior-superior, and you may hit the incus and the facial nerve if you go a little bit down. So even with Dr. Ali, with socialization, I am very much positive with Dr. Ali, with socialization of the upper limit of the mastoid. You may keep the edges or the overhang in the rest of the mastoid. Thank you.
Professor Bilal, the posterior tympanotomy, can you comment?
الصوت يا دكتور عزيز.
Dr. Aziz, unmute please. Yes, we can hear you now. Unmute يا دكتور Aziz. Yes, now it's unmute.
طيب يعني I want to comment on the cortical mastoidectomy because it's such a pleasure to work on a normal mastoid to your cortical mastoidectomy. This is first. I think the crucial point about cortical mastoidectomy for cochlear implant is the sinodural angle, because the sinodural angle is the angle where you look through the posterior tympanotomy. So unless you really open the sinodural angle, you're not going to see well through your posterior tympanotomy. Then I'm not going very far, like Ali has said, into towards the digastric ridge. I think drilling downward there is not really needed, because you need to do as little work on the mastoid as possible so that you can have bony edges to keep your implants. Now your question is with your posterior tympanotomy, you said, Fathi, or?
Yes, posterior tympanotomy. What are your tricks and how do you find it? Is it large? Do you do it large, small? What are your tricks and tips?
Well, the main trick is that you expose the incus. Exposing the incus, then the incus itself points towards where you should start drilling into the posterior tympanotomy. There is a very important point about pneumatization of the facial recess, because the air cells around in the area of the posterior tympanotomy doesn't have to do anything with pneumatization of the mastoid. You can have a very well pneumatized mastoid, but the facial recess is not pneumatized. There is a very important point that we have to bring also, especially for junior surgeons, that the dimensions of the posterior tympanotomy or the facial recess are the same the day that a baby is born. So it does not get bigger as the time goes. You can go into a 6 months or 8 months child and find the facial recess with the same dimensions like an adult. So this is a very important point also that you have to bear in mind.
So I would summarize, Dr. Aziz is usually looking for the incus because it will point, because it will point to the facial nerve, and he do it a large posterior tympanotomy, and as he mentioned, the facial recess, you can look it for the CT beforehand. And Dr. Aziz, do you keep a buttress or you remove the buttress? You didn't comment. Please, can you comment?
The buttress of the
incus buttress.
The buttress of up there, you'll have to do it. It depends really on seeing the incus. You have to see the incus well, because the incus points into where you should start opening into your facial recess. So it depends. You drill into the root of the zygoma, like Ali said, until you expose the lateral semicircular canal and the incus, and from there you can go down into your facial recess.
And one of the tricks that you remove this area to bring light inside. Dr. Ali, you want to comment?
Well, the first point is actually regarding the digastric ridge. I go down there with the whole point when I actually loop the electrode array into the mastoid cortex. That would support my electrode array. That's the whole point, is to create a ledge of bone to support the electrode array rather than going deep to the level of the facial nerve. So that's the first point. Regarding the posterior tympanotomy, I always recommend actually that whenever we operate on these patients, we need to have a table that you can tilt it away from the surgeon and tilt it close to the surgeon. So when we start doing posterior tympanotomy, I always ask the assistant or the officer in the OR to actually tilt the table away from me. In that way, I would be actually seeing very well the bulge of the lateral canal and the shorter process of incus. And I also can see the posterior bony meatal wall. Because if I breach this bony wall, I can actually see the skin of the posterior meatal wall. Now, in doing the posterior tympanotomy, Prof. Fathi, I actually tend to really go very medially towards the facial nerve. And I always state that the facial nerve is our friend, is not our enemy. So I go as much as possible medially, and I would rely on the color change, the tone change of the bear, and if there is any bleeding on something, then I know that I am close to the facial nerve, let alone drilling parallel to the facial nerve with plenty of irrigation as well. That is very important to avoid any collateral thermal damage to the facial nerve. And the second point is, when I drill and I open up the posterior tympanotomy, I know there's quite a lot of bone medial to the facial nerve that needs to be drilled. But once I open up the posterior tympanotomy, I ask the officer in the OR to tilt the table towards me so that I would be able to see medial to the facial nerve until I expose the pyramid and see the stapedius tendon as well.
I think one of the tips also that you should always look for the shaft of your burr during drilling, not to injure the facial nerve. And as Dr. Aziz said, you can predict your facial recess by looking to your CT before, because sometimes it's cellular and sometimes, as here, it's very sclerotic, so you know beforehand. And we had a thesis where we proved, as Aziz mentioned, Bardo, that this has nothing to do with the cellularity of the mastoid.
Yeah.
Professor Shazli, the anterior sigmoid sinus. This is the sigmoid sinus, which is far anterior. What you do usually in such cases? Shazli, unmute, please, Shazli.
It's right. That's okay, Samani?
Yes, please. We can
Yeah,
hear.
when we look at such a line which goes through the basal turn of the cochlea and the posterior tympanotomy, you find that the direction of vision is hindered by the sigmoid sinus. I always believe that the relation of the cochlea and labyrinth is a steady state. I mean, it's not, it does not change. And there is always a room to go through a posterior tympanotomy to reach the round window. So what we have to think is how to mobilize the sigmoid sinus. How to mobilize is you can make such mobilization for about 1 or 1.5 centimeter by pushing over it. But the trick in it, you have to keep a piece of bone you are, after thinning out of the cortex of the sigmoid. And you use such Bill's island, you call it the Bill's island, and to push the sigmoid sinus with such island of a bone. But sometimes what we do is after thinning the cortex of the sigmoid, we crack it down. So we are making as a retraction, like an egg shell. كأنها قشرة بيضة بتزق عليها, فيو are keeping. And I think this is the best way to do it.
Ali,
sometimes if you lose food,
Okay.
Sometimes if you lose the bone, you may use a piece of foil, push over the sigmoid while working into the posterior tympanotomy.
You mean the
This is
aluminum?
a high jugular bulb.
Okay. Ali, this is a patient scheduled for CI, and you can find the jugular bulb is very high.
Yes.
And including the round window. What you can do?
Well, with these patients, I would probably modify my approach a little bit. So instead of leaving the buttress and incus, I would probably remove the buttress and incus to widen my posterior tympanotomy. And if possible, if I could pass a fine-tipped bipolar and try to shrink this bulb, I would do. If I can't, what I actually do is to use what I call actually foil. You know, the sheath of the Vicryl, 3O Vicryl, the one that we usually use. The sheath of it is like aluminium foil. I take a small piece of this foil and try to cover the bulb and push it down as much as I can until I actually see the round window. But if the bulb is too high up or diverticulation of the bulb, probably I would do it a staged procedure, Professor Fathi, after compressing the bulb, and I would do the implant at another time.
And if there is accidental bleeding, what is your protocol?
Well, because it's a venous bleeding, in the majority of times, this can be easily controlled actually by compression, by the use of Surgicel. And I would obviously lift the head of the table a little bit, lift it to like 45 degrees to actually minimize the venous pressure. But in the majority of times, the venous bleeding is easily controlled by compression. I would actually use a piece of muscle from the vicinity muscles like the sternomastoid or something, and I think that is a very good hemostatic agent. Using the muscle, the striated muscles are well known to be a very good thrombogenic agent.
Professor Bilal, this is a round window, and there is a structure here. Can you comment on this structure? What is the importance of this structure? How it can mislead us?
I want to focus on the jugular bulb because, again, I'm not with Dr. Ali that it's a simple venous bleeding and it's easily controlled. I think the worst experience that you can see is when you're turning a tympanomeatal flap in a myringoplasty or stapedectomy, and then all of a sudden you have a major jugular bulb bleeding. It's one of the worst nightmares that you can meet. But when you use Surgicel on the jugular bulb bleeding, you have to be very careful because you shouldn't use small pieces of Surgicel because otherwise they will go down the jugular, the internal jugular vein and into the heart and cause major problems. So, I mean, you have to be very careful. In this case, I think I'll change my approach in cochlear implantation and do a combined approach. So I would turn a tympanomeatal flap, taking care, of course, of the inferior incision, doesn't encroach on the jugular bulb, and avoid doing a round window insertion of the electrode. I think I'll do a cochleostomy, which is anterior to the round window, and put the electrode through a cochleostomy because the jugular bulb will be in the way of putting your electrodes, as you can see very well in this CT scan. Again, going back to the picture of Dr. Fathi.
Dr. Aziz, please, just because I remember saying, we have to warn also the anesthetist that we have a problem with the jugular, so that he should take care about the air embolism and so forth. Back to Dr. Aziz for this picture.
This is a very common mistake that junior doctors are falling into, and they think that the lower thing that Dr. Fathi pointed now is the round window. This is not the round window. It's a hypotympanic air tract or air cell, and usually they put the electrode down there that goes up into the petrous apex. And I've seen many cases where the electrode was misplaced. Instead of going into the cochlea, it goes into the hypotympanic air tract. So you have to be very careful in your anatomy. This you cannot get except by doing so many temporal bone dissections.
Okay, thank you.
Can I?
Yes, Ali?
Actually, to Professor Bilal, when you approach, in case of high jugular bulb, Prof. Bilal, when you approach it through lifting the tympanomeatal flap, actually, you're gonna face the jugular bulb in front of you. So, but if you approach it from superiorly, you can actually compress it down. So approaching it through the posterior tympanotomy after removing the incus and the buttress, you're gonna push it down. But if you approach it from the tympanomeatal flap, it's actually in front of you and it's not easier to push it down. That's why I said to actually approach it from superiorly. So it's a different opinion.
هي بس القصه دكتور هي الايشو دكتور علي what Dr. Aziz I think what he meant for is this jugular bulb is overriding the round window.
Yes.
So that's why you should find another way to insert the electrode. It's not the issue of how to reach this area.
Yeah, but the other approaching it through the external auditory canal, actually the bulb is more in front of you. It's not easier to push it down, but you can easily push it down from superiorly rather than from anterior. That's why.
What I mean in such CT scan,
Professor Shazli?
the jugular bulb is over the round window.
No.
So how much you are going to displace to reach the round window and put your electrode? This is a big issue. So cochleostomy, I think this is maybe one of the few cases that really needs a cochleostomy to insert your electrode.
Professor Shazli, this is a straightforward case. It's St. Thomas classification 1. You can see the round window very clearly.
Yes.
Do you go for round window or cochleostomy?
I mean, my last cases, I mean, it's large disease. I mean, I go always through the round window, and I don't think that I have never found a real difficulties to reach the round window.
Your opinion?
No.
Professor Shazli, also, this is the round window is not very visible, and an overhang from the promontory.
Okay.
And, what do you do in this overhang? What are you?
I'm calling now what I go for the trans-Stigman approach of the round window. So I can drill for the superior overhang, and I can nicely reach post-superior overhang, and I can reach very nicely the round window. And when we are talking about the I mean, you have to take care not to go for more drilling so you injure the hook region. So instead of post-superior part, a little bit more superior, you are going to find the hook region.
So you avoid the hook regions, and your drill is you put it in a low speed to avoid the.
Yes.
And about this area, Chesley, if you find an
yes, the Crista Fenestra. I mean, I try sometimes to go with the hand bear to remove it after making exposure of the round window with a hand bear.
Some people bring a hook and then from behind it and okay. Because if you leave the overhang and the Crista Fenestra, your electrode will be directed to the modulus and will go to the scala vestibuli. But removing the bony overhang and the Crista Fenestra will be sure that you are going into the scala tympanotomy. Dr. Aziz, if you don't find the round wind, which are very rare conditions, but you did everything, you rotate the table, and you didn't find the round window, how could you find your landmarks? And
we've met few cases like this. I remember one case was yours, and we had to go again through the exploratory tympanotomy through a combined approach. Once you go into the middle ear from the front, then you see all the anatomy, I think, in a clearer way, and you can approach the round window and do your drilling and everything through this combined approach. So I like to do this if you find a problem. Again, using endoscopes has helped so much in seeing the round window and putting the electrode in the right way through the. We have beautiful pictures, as you have seen in one of our juniors doing a thesis on this. So I think using endoscopes in this particular situation is very important.
So our options are either a wide posterior tympanotomy and rotate the table, as Ali said before, toward the surgeon. But usually you have to be ready with the strap, or we do the transcanal endoscopic to detect the round window. Or if you want to do a cochleostomy, but you should be aware about the anatomy and you look for your stapes and do your blind cochleostomy, which we can keep it at a last resort. Ali, would you give any local applications? Now you are on in the round window. Before opening or just after opening, do you instill any Helon steroids, or you don't instill anything?
I used to instill both steroids, but not anymore. There's no evidence to support actually either. So, but when I initially started, I was actually using both Helon and steroids, but as I said, not anymore.
What is against installation? Because maybe suction, you will need suction, and suction will do some harm, maybe.
And actually, you may push some bone chips into
bone chips inside.
So,
what are your tips and tricks in electrode insertion?
One I'm talking, two kinds of electrodes, straight electrodes like that of pedal, cochlea, and as the routine is the soft surgery. We go very slowly. It takes about 30 seconds or 45 seconds to insert most of the electrodes, and we go in a steady way. But if I'm talking for premodular electrode, I have a small trick, which is if I am using on the right ear, I am using the left hand. If I am going for the left ear, I'm going with the right hand. It's very important to go with the direction of the visual turn of the cochlea.
As Dr. Shazi said, the most important is to go very slowly, and if there is any resistance, don't push because it might kink your electrode. Any of the panelists measure the cochlea before going to surgery?
Fathi, can I comment on a little? سامع صوتي ولا?
Yes, very, very, very clear.
I want to comment on using steroids. You use steroids in cochlear implantation so that the vestibular symptoms and the dizziness of the patient after the surgery is much less. I think it has a role in doing this. So I routinely use dexamethasone in my cochlear implantation for this purpose. Getting back to your electrodes, I think it's a very important issue that we should discuss. The length of the electrode, whether it's too long or too short. And I'd like to hear the opinion of my friends, because I've seen so many publications showing an electrode going into the apical coil, and they were very happy of having a full insertion of the electrodes up to the apical coil. And you know that Medel is coming up with a 31 millimeter electrode to do a full insertion. I think I'm against this because of physiological considerations. I think that we are stimulating the spiral ganglion cells, and these are present in the modiolus. The modiolus do not reach the apical coil, so there is no idea of reaching the apical coil while there is no spiral ganglion cells there. If you tell me about tonotopic organization, again, I do not understand that we can replace 30,000 hair cells with 22 electrodes and we still get speech discrimination. So these points are, I would like to hear your opinion about
I think, Dr. Aziz, most of the people now is going to the shorter electrode, to less than 31. Even Medel, they recommend more 28, and they have now the 26. So I think we are now between the 28 and the 24 electrode. I speak about the lengths, unless there are some conditions which we are going to discuss.
And I think that
Shazli, we don't hear you, Shazli. Ali, you want to talk until Shazli come back?
Well, ideally, one would measure the length of the cochlea, and that would actually determine the length of the electrode array. But in practice, what happens, to be perfectly honest with you, well, in Egypt here, we have a certain number of devices for a certain number of patients, and you just operate on them in the morning. In the morning of surgery, you have the device. To be perfectly honest with you, I would insert as gentle as possible, and I always make it a habit for my assistant to count from 1 to 30, and I would insert it once I confront a resistance. I would stop, and if the number going in is enough, then I would stop. Otherwise, I would change the angle of my insertion until I would insert it as fully as possible.
I think one good idea that you discuss with your radiologist to have this software, and he can in the report write to you exactly the length. It's good to know the length of the cochlea beforehand. Shazli, did you came back? Shazli, can you hear us, Shazli? Dr. Aziz?
Yes. Hello? Yes. I think if we are talking about a Passepartout electrode, I would go for the 24. If you compare the three companies, they are almost the same size like this. And I would prefer to have all the electrodes inserted, احتمالية the instance of full insertion of any electrode, whatever the length is, than to get shorter or lesser number of electrodes which are in. So my recommendation, as Dr. Ali have said, we go for one chance for every patient. I would recommend that, especially for Medal, we use 24 for any case. I am sure that we are going to get the best results.
Okay. Shazli, do you use the lateral wall or the perimodular or the mid-scala? In most of the cases, I mean.
In most of the cases, is lateral wall, as you know, that we are obliged to use it for the companies. Most of them are lateral wall, but I think that the mid-scala is the best.
Dr. Aziz?
And I've tried all these kinds of Fathi. The perimodular are the best in their results because you expect your electrodes are very close to the modulus where they stimulate the spiral ganglion cells. But the complications are more with perimodular. So now everybody is doing a lateral wall to be sure that you have full insertion and you do not cause any complications.
I think at the end of the day, Dr. Aziz, all of them give more or less good results. Ali, if there is an incomplete insertion, how many electrodes you are satisfied if they are inside the cochlea? Depending.
Can I just go back to the previous question, Prof. Fathi?
Yes,
I mean,
please.
the choice of the electrodes, actually, the pathology we're dealing with would dictate on us the choice of electrodes. So if I'm dealing with a case of autosclerosis, far advanced autosclerosis, for example.
Ali, can we speak only now? Ali, can you speak about the normal case, and then we are going to speak about the different case.
Okay. So your question is about the incomplete insertion. Is that your question? Yes.
Yes.
Well, the number of electrodes that I would be satisfied with, I have to say to you, Prof. Fathi, that we need to think about this from the practical sense. Now, when you have a device, you would try to be as gentle as possible in inserting it fully. Now, if you meet a resistance, you would try to change your angle of insertion without undue force, without any excessive force. Now, and that is the best that you can do from the practical standpoint. But if you ask me about being satisfied or not, I would probably say an arbitrary number for every different implant. So if you have an implant with 12 electrodes, probably 2/3 is a good choice for me. 2/3 meaning 8 out of 12, 10 out of 16, 14 out of 20, 16 out of 24.
Okay. So the 2/3 is the rule in such case.
It's not a rule. This is an arbitrary.
More or less, I mean, your opinion, Dr. Aziz. Okay. Dr. Aziz, do you do a bed or not? And do you implant do you fix your implant? I don't speak about the one who has screw, because if he has a screw, it will be fixed. But my question is, if there is no screws, do you fix your implant or not?
Yes, I like to have a bed.
Yes.
My implant with sutures. I like to, I do not like this. I've tried this subperiosteal pocket, and I think the implant is not very stable. So I think to make a bed and to put some sutures, you are absolutely sure that you don't have an implant that is moving, which is very important for not to have complications.
You feel more safe.
Yes.
I think one of the most important trick I found is that after doing your bed, you have to do a copious saline irrigations. Because I did a study in UK, and I found that this is one of the factors which reduce infection very much. But copious saline irrigation is an important. Before going to challenging case, we have a few questions for you. Do you do endoscopic assessment through the tympanotomy approach? Is from our colleague Tamer Abeid, whom I greet him over the webinar. Anybody is using the endoscope through the posterior tympanotomy?
No.
The infracochlear tunnel and structure like that? I think it's too big to look, and the problem of sterilization. I don't. Do you have any comment, Dr. Aziz?
Only in challenging cases where the round window, there is a problem with the round window, a blocked window, you cannot find it. I think then you can use the endoscope to to help you to find those
to
things.
see it.
But, as it's a forward case, I would not use the endoscope routinely.
His second question, do you use facial monitor? Any of the panelists use facial monitors?
I used to use it by law, but not anymore.
Here, it's different.
I never used the facial monitor.
Okay. Challenging case, Dr. Shazli, this is residual hearing. He has a low frequency, good hearing, high frequency, hearing loss, and he is not benefiting from the hearing aid. What are your recommendations in such case? Shazli? Shazli, unmute your microphone, please.
Yes.
What's the speech discrimination on this?
Not using, I mean, not benefiting from the
hearing aid.
Hearing aid.
Less than 60% estimation.
I would go for cochlear implant using medium-sized electrode. If, for example, it's 24 electrodes.
Medium or two?
Huh?
24.
24, yes.
24. Ali?
Well, I'll probably do the same, but if I have the hybrid electrode, it may be a good idea to use to have both acoustic and electrical stimulation.
But after a while, he will need to use a longer electrode. So I think
some of them might. Some of them
hybrid, even the hybrid.
I think the 24 is optimum. I mean, you are not distracting the apical turn, you're not reaching the apical turn, and at the same time, it will work for long-term hearing loss.
I think most of the people do such technique, except Thomas, who use a long electrode, 24 or 28, and then he push it only for a few distance. And if the patient lose hearing, he go for reinsertion.
No, we don't have this luxury in Egypt, Professor.
We don't have. This is an international webinar, Ali. Middle ear effusion, Dr. Aziz. This is a child with middle ear effusion who had a lot of treatment with no response. Do you do a grommet and then cochlear implant, or you do both of them together?
Yes.
What is your
1 week before cochlear implant, you do a myringotomy and tube, because if you go into cochlear implantation with the effusion in, you have a lot of congestion. The anatomy is all mixed up. So I think it doesn't do a difference as far as post-operative meningitis and all of that. In 2 weeks after doing a cochlear implant, there is a fibrous sheath that closes down the round window completely, and there is no danger of meningitis.
You do a grommet or just a myringotomy, and because to leave a grommet inside the patient with a cochlear implant, or do you wait for until the grommet extruded? What is your protocol? I mean,
I put a grommet and go ahead with the cochlear implant.
May I have a comment?
Leslie?
Yes, you're hearing me.
Yes.
Hello?
Yes.
And if I have in such a patient a primary pathology that would cause such a condition, for example, adenoiditis or sinusitis and persistent nasal discharge, I would go first for treating the primary pathology. But if I have a condition like this without a primary pathology, I would go with the CI in spite of the presence of the middle ear effusion. And concerning what Dr. Aziz has said for the congestion or edema, once I am doing the posterior tympanotomy, I am preparing the middle ear with adrenaline and corticosteroids until I finish my bony work, and then at such time, during such time, the mucosal edema would subside and the extensive bleeding would subside. So I would go for CI, and I think by doing the cortical mastoidectomy, you are relieving most of the pathology which could happen in the middle ear.
Ali?
Well, the management really depends on the situation. Sometimes you see the patient the morning of surgery and you have effusion. You have no alternative but to go ahead with cochlear implantation without doing anything for the effusion. As Prof. Leslie said, you're going to prepare the middle ear as you go along. But luckily, I have not had any significant infection after surgery dealing with an effusion candidate. But if you see the patient beforehand, I think I would treat this patient medically first. And if they do not improve, then I would go ahead with ventilation tube insertion. But that's provided that you see this patient well before the surgery.
طب can I have a question, Dr. Fathi, من فضلك?
Yes, please.
Dr. Ali, if you are going to make a tube, for how long you are going to wait for the tube to work? And in such way, the patient is losing time for CI. For example, are you going to wait for 2 months, 3 months, remove the tube, and then make a cochlear implant?
That's why Prof says. That's why I said it depends on the situation. If they have the luxury of time, I would leave it until it falls out. But however, if the time of surgery is approaching, what I would do, probably I would remove the tube 2 weeks before surgery, making sure that the tympanic membrane has healed up well before embarking on cochlear implantation.
So you are going to anesthetize the patient for 3 times. One for the removal of the tube, one for removing of the tube, and the third for CI.
No, not
too
really.
much.
Removing the tube does not require general anesthesia, does it?
Yes.
Yeah, I wouldn't do it for a child. No.
I think I agree with Shazli that it's difficult, but it's doable, and I would be afraid to leave a grommet with water in beside. It would be for me a problem maybe. Dr. Aziz, I know your protocol, but I want to hear it from you in cholecystoma. Before cochlear implant, do you stage it or you do it one stage?
I like to stage this. I do a subtotal petrosectomy and rainbow operation, close down the external auditory canal, and then mark the place of the round window and come 6 months later to put my electrode.
Okay. Any other opinion? I don't think there is another opinion.
Can I just ask Prof. Bilal about the rainbow? What do you mean by rainbow? And how would you mark the round window?
The rainbow is the name of the surgeon that it's like Rambo, you know the Rambo.
Total petrosectomy, you mean? Yeah, okay.
So you do subtotal petrosectomy and close down the external auditory canal, and this is what they call the Rambo operation. Whether you obliterate the whole thing with fat or whatever you want to do. Some people do not. They choose not to obliterate and leave it with air. But I like to obliterate with fats from the abdomen, and I mark the place with a suture or a blue suture or something over the round window, so that when I go back in the second surgery, it will be easy to find the place of the round window.
You don't place a dummy electrode, Dr. Aziz?
Well, it's a good idea that you place bardo a dummy electrode. But usually in those cases, it doesn't really ossify. Some of the cases of chronic otitis media, they have some ossification around in the base of the thigh, but depends if the round window is open and everything. So we don't in the first case, because of the infection with the cholecystoma, we're afraid of inducing labyrinthitis.
Ali, the kind of electrode do you use in otosclerosis?
It's emphatically the perimodular electrode, and that is very important to avoid the inadvertent facial nerve stimulation in these patients.
So this is we have to keep it in mind in otosclerosis. If you use a lateral electrode, there will be facial twitches and you have to reprogram the patient.
In otosclerosis also, you have an incidence of round window obliteration and invasion of the scala tympani in the basal column. But this you realize by CT scan before the surgery. And one thing that's for otosclerosis, that the drill out of the round window and the scala tympani in the basal coil is much easier than labyrinthitis ossificans. The bone of the otosclerosis is spongiotic, otospongiotic, rather than a very hard bone like you find in labyrinthitis ossificans. So in otosclerosis, usually your drill out will succeed.
We discussed meningitis in the last webinar, but one point I want to stress that we didn't mention it last time, that in case of meningitis, besides looking to the ossification and the problem of the cochlea, we should look if there is any cause for the meningitis or not, because otherwise the patient will, or the child will have recurrent attacks of the meningitis. Two important areas to look for: the foot plate of the stapes. You can find the small fistula in the foot plate of the stapes and you cover it. And there is what is called the Hirtel fissure, which is a rare condition, but it could be a site of meningitis, and you have to close it by a way or another. This we didn't mention, so I would like to emphasize. The inner ear malformation, there will be a special panel on inner ear malformations. Please don't miss it, because there will be a lot of pictures, and I think it will be a very good radiological demonstration. Shazli, a child, very young infant, 6 months, 7 months, you have to do it. What are the problems do you expect?
سمعني كده ولا؟
Yes.
Yes. I mean, when we are talking about a child, I would think about general and local. General is this child has a very small amount of blood. So whenever I decide to do CI for him, there should be extreme necessity for doing it at the age of 6, for example, 6 months, for example. Otherwise, if the child has nothing except such congenital hearing deficit, I would wait for a year at least. But when we come for an emergency like meningitis, I would think about the intraoperative bleeding. So I should care very much about not losing blood as a minimal amount of blood during surgery. When we come to the local problems, is the position of the facial nerve in such condition. It's almost at its vertical part, it's very near to the skin. So by doing the incision, I should put in mind that the skin incision is a little bit posterior and superior away of the facial nerve. As Dr. Aziz has just said, that the posterior tympanotomy in a child is not that difficult. I mean, it's even could be less difficult than doing in older age. But the problem when you are using a thick implant, there's going to be a protrusion over the bone, and in such condition, you may have a bulge under the skin, and the skin is under tension. So when you are making a bed, it's better to do a bed to, to insert your implant, but put in consideration that the thickness of the skull at such age is very thin. So sometimes you may some form of displacement of the dura a little bit down, so it can accommodate the implant you are using. Otherwise, you can go in a normal way for implantation.
Just I want to add that the mastoid is diploic. This is why bleeding is...
Sometimes, yes.
Can I add something on this? The minimum age of cochlear implantation has been moved from 1 year to 9 months by the FDA. So the FDA now has approved that you...
The 9 months.
Yeah.
Which is logic, 9 months, so to be sure that he is not benefiting from hearing it. I think 9 months is reasonable than 6 months. I don't know. Now there is more and more doing cochlear implant under local anesthesia. So for cases where there is any problem, we can go for Now, before going into evaluations, there is a question about the suprametal approach. Anybody want to comment on the suprametal approach? I usually find that the direction of the electrode in suprametal technique will be a little bit difficult. I think the posterior tympanotomy is usually the gold standard in our condition. Any other comment? No. Intraoperative evaluation. Ali, do you rely on ECAP or you do stapedial reflex? What do you do in the operating room after finishing the operation?
The ECAP and the impedance are the two primary intraoperative electrophysiological testing, really. Again, when I initially started, it was actually the stapedius reflex, where you would give this sound and then you would see the stapedius tendon moving in front of you, which is really good for the surgeons if they would like to see it. But of late, obviously, ECAP and the impedance are the primary electrophysiological testing intraoperatively.
I think the stapedial reflex, you are sure that the implant is inside the cochlea. I think it gives a very good help to the surgeon.
But actually, the whole world now, Prof. Fathi, has shifted from using the stapedius reflex to the ECAP, because the ECAP is also very good now, actually, in detecting.
Can I have a comment on stapedial reflex, Dr. Fathi?
Yes, please.
I have seen some of the cases while introducing electrode. The electrode, after advancing a little bit in the cochlea, shifted into the superior semicircular canal. In such a condition, the proximal electrodes would stimulate the sound, and you're going to get a stapedial reflex. So I think, I hope that you understand what I mean. Even if you go wrongly for the pterygoid canal, it would happen that you're going to have the stapedial reflex.
And you will have an ECAP also.
You cannot substitute the ECAP by the stapedial reflex. ECAP would give you the whole, most of the electrodes either are working or not working.
Okay. Dr. Aziz, do you do routine intraoperative imaging, or it's only if the condition is not satisfactory?
If it's not working, then you do intraoperative imaging. Otherwise, we don't.
You don't do. The tip fold over, you can miss the tip fold over. You'll find the ECAP is good, everything is good, and you miss the tip fold over, and then you discover it after a while. I think if we can take the practice of doing routine imaging, this will be good. I usually don't do routine. The misplaced electrodes are three kinds of misplaced electrodes. The first kind, where there is no problem. The patient has no problem, and its removal are easy, like the infracochlear and the Eustachian tube. As Dr. Aziz mentioned, there is a lot of children who have an infracochlear in the tunnel. And the second one, where there is a problem to the patient, especially vestibular symptoms, like the one in vestibule or in the superior semicircular canal. But its management could be a little bit easier. The main problem will be here, where it will be either in the internal auditory canal or in the carotid artery. Shazli, if you find the electrode in the internal carotid artery, what is your technique in revision?
I think if it's an internal auditory canal, I will withdraw it. I mostly is going to be between the wall of the carotid, the bony wall, and
internal auditory canal or carotid now?
لا بكمل internal auditory canal. Sorry, internal carotid.
Internal carotid. So
I would withdraw it and reinsert it. And I never face a condition of the internal auditory canal, but I would cut it and put another electrode.
Back to the carotid canal, you are not aware and afraid of having any problem with the carotid artery. I think the least we can do, we have to have a standby vascular surgeon just in case of any problem. I would be more secure with that. About the internal auditory canal,
what is going to do?
if any vascular, they can do some. They can manage it by.
They will not. I mean, except if you balloon occlude the
This is what I mean, balloon occlude.
Fathi, can I tell you about a case that I had? They called me and they said this was a case at the university, and they said that the surgeon cannot get the electrode into the cochlea. Every time he put the electrode, it was pushed back. And I went and I found that he was trying to put the electrode into the carotid canal, and then the pulsations were pushing the electrode back. So fortunately enough, he wasn't very adamant of perforating the carotid or something, and things went right. But I think for the internal auditory canal and the carotid canal, if you get one of those cases, you should cut the electrode and leave it, because in the internal auditory canal, you can avulse the vestibular and the facial when you're pulling out the electrode. And in the carotid, you can hurt the carotid. So maybe you can cut it and leave it. Well, there is no problem of doing this.
I think I agree fully with you, Dr. Aziz, because you can avulse the cochlear nerve. And this is from a book of Mario Sanna, where he cut the electrode. It was in the carotid canal, and then place another electrode. It will be more safe than having the hazard. I will go.
Do you think, Dr. Fathi, لو الجراح had put the electrode in the carotid, would it bleed?
لا, it will go between the carotid artery and the wall.
That's why I am telling you that, I mean, you can withdraw. I mean, working in the lateral skull base, the carotid is not that soft. I mean, you cannot go with a silicone and perforate the carotid. We never.
Muhammad, if you leave it for a while and you come back maybe in a few months or a year, there are adhesions between the electrode and the wall or the sheath of the carotid. So when you're pulling the electrode, you can.
It's a silicone, doctor.
Yeah.
It's a silicone material. I mean, it will never react with the carotid.
يعني مش عارف يا محمد.
You have a point, but يعني it's.
If one case happen, يعني it will be a nightmare. Now the infections, we will divide them into two big categories. A simple infection like this. Ali, what you do in a simple infection around the electrode?
Can I say something here? Having a red area like this doesn't always mean infection. It could be the strength of the magnet. If the magnet is strong, it may actually lead to something like reddish area of the skin here. But obviously, if
how can you differentiate between? How can you differentiate between them? I mean, there will be red area.
I was coming to this. Now, clinically, when you see this child or this patient or this candidate, what you actually see, if this is an infection or inflammation, it would be tender. And you would see constitutional symptoms with it if this is an infection, like fever, like malaise. In addition, if you do like simple CBC, then you would see signs of infection in there. But that is provided that is just a reddish area. But obviously, if this area is fluctuating, then you don't.
No. Ali. We speak about simple infection, not fluctuation. No. This simple infection. How do you manage?
Well, with these patients, I would be extremely cautious, and I would probably advise hospitalization. Give them triple antibiotics. And keep very close eye on them, because if this infection is not controlled, you're gonna lose a precious device in there. So I would really gingerly deal with them, hospitalize them, give them the maximum doses of antibiotics and close follow-up.
Shazli?
I think this is a simple erythema. Would go with very mild local cream. I mean, implant off for at least 2 weeks, and antibiotics that would solve the condition.
What organism you suspect, Shazli?
I'm like most of the organism of the hair follicles, staph, or it's just, I mean, it's cutaneous infection. It's a simple infection. I mean, it's
I
not
agree with
subcutaneous.
Leslie. In such case, we do.
Prof. Fathi, can I just point on to this? I think with this reddish area, it is better to err on the side of caution. So it is better to deal with it aggressively and get rid of it rather than assume it's a simple infection and then you would end up explanting this device. That's why I'm dealing with this a bit extra cautiously.
Yani Ali, look at this picture and the following picture, which has been just removed.
This condition need hospitalization.
This condition is a subcutaneous infection. The first one is cutaneous. This is a subcutaneous infection. I will go for aggressive treatment.
This one needs
I may open it.
My point, Prof. Shazli, is in case of cochlear implantation, I would err on the side of caution because this is, I have a device, very expensive, and I don't want to look.
Ali, we have different opinions. Yeah, no problem. These conditions, it will need hospitalization, and we have to give very aggressive treatment and antibiotic against Staphylococcus, especially MRSA staph, to avoid having biofilm and the problem of skull breakdown, which might need to end to extrusion. And this is one of my cases, and with antibiotic, with aggressive treatment, at the end it can close. So we should not always lose hope that you can give aggressive treatment.
But this is different from
the other. I know.
Yeah, it's totally different.
Totally different. Pain around the implant. Any of the panelists would comment? This is a child who had a cochlear implant 8 or 9 months before, and then now she's complaining of pain around the
just pain, huh? Just pain.
Pain. And the pain is continuous. It has nothing to do with putting the apparatus or not.
Can I answer this?
Yes, please.
Yeah, well, pain around the implant, I would think of infection. I think that's something that I would really consider seriously here. But obviously the differential diagnosis can be, I mean, the child is not, some children are not very descriptive. So you wouldn't really rely on them telling you the pain is here or there. So this could be, this could herald the infection, but it also could herald a soft failure of the implant, particularly if the parents are complaining that the child are not hearing well in the last few months or few weeks. But again, the pain around the implant could be to do with the strength of the magnet as well. But I think infection comes first.
I think we have to consider it as infection until proved otherwise. We have to give antibiotic because when they follow this patient with nuclear scan, they found evidence of infection. Meningitis, I will not go through. The complications, the facial nerve injury, we mentioned it, the device failure. Maybe we don't have enough time. And the last item, maybe the post-operative, this patient need a brain MRI. Do you consider tight bandage or do you consider removal of the magnet? The neurosurgeon asked for him a brain MRI for another reason. Would you consider only tight bandage to secure the implant, or you want to remove the magnet? To cut it short, this is the difference between with the magnet in and with the magnet out. The neurosurgeon can see the pathology far better. Any final remarks from the panelists? Dr. Aziz, do you want to?
I would like to thank Dr. Fathi first for his kind words. We've been colleagues and for more than 40 years, but we've been friends more than colleagues. So I know his family, and they are dear to my heart, all of them. Ali, I always enjoy teasing him in panels. So we'll always meet again and have contradictory views. Muhammad, I have all the respect for you and all the Asr Al-Aini professors. My father was a Cairo University professor, and this is why I love everybody coming from Cairo and Asr Al-Aini Hospital. It was a pleasure for me to be in a panel, and we'll look forward to meet again, inshallah.
Shazli?
I'd like to thank Dr. Fathi for such big effort he's doing for the otology and CI and the CME. My great respect to you, to Dr. Aziz Bilal and Dr. Ali for their kind meeting, and always looking forward to meet again and discuss such scientific issues.
Professor Ali?
It's to thank you, Professor Fathi, very much indeed. It's always a pleasure collaborating with you. We have been now for the last 6 years or so, actually on annual basis, collaborating together. And I have to say that your perfectionist personality is very educational to me. You just look at every details and you are up to it. So, and I thank Professor Bilal and Professor Shazli. I'm very glad to be with this distinguished panel.
I'd like to thank you all, and you can watch this video after 1 week or the other videos before on youtube.com/c/OTOALEX. And what I want to say that this platform is open to any person who would like to present on CI, whether it's a case presentation, whether it's how I do it, whether it's a panel. It's an open platform. So I'm looking forward to hear from you for the next episodes. And thank you again. And I would like to thank you, Blue Sky, actually. Blue Sky is doing a perfect job. Engineer Wael was with us. So I would like to thank all of you, and see you soon after the corona subsides, inshallah. Okay, bye-bye.